Hello and welcome to the Rural Doctors Program. I'm Jerry Gannon. Thanks for your company this evening. Well now, firstly tonight, a big thank you to everyone who attended the Rural Health West Annual Conference. It was great to see so many of you there, and I certainly enjoyed it immensely, and I hope you did as well. You may have seen our producer, Simon Stokes, walking around with a camera. Well, he followed up some of the discussion forums at the conference by asking some of you to give your views on the role of the GP within our communities and how to make rural and remote practice more sustainable. And we'll bring you some of your responses later in the program. This evening, we have no specific clinical focus. Instead, tonight's program is an opportunity to call in and discuss any aspect of the running of your practice. It's also an opportunity for you to give us some of your hot tips. So if there's anything you do within your practice that you think would be helpful to others, then please give us a call. And later in tonight's program, we'll talk to Professor John Murtagh to get his hot tips for GPs. But right now, let me introduce our panel for this evening. Firstly, our very own Dr. Olga Ward will be helping me lead the discussion tonight. Welcome, Olga.
Thanks, Jerry.
And I'm also delighted to welcome Max Kamian, Emeritus Professor of General Practice at UWA. Welcome along, Max.
Thank you, Jerry.
And also with us tonight is clinical lecturer, former rural GP and occasional host of the Rural Doctors Program, Dr. David Jamison. Welcome, David.
Thank you, Jay.
And thank you for coming. Now, remember that you can have your say or question our panel at any time by giving us a call on 1-800-673-277 or 08922952241. So get on the phone now if you have any questions or if you have any hot tips that you'd like to share with us tonight. So to get the ball rolling, I wanted to ask all of you briefly to give your advice on some of the more common problems or presentations. Now, Olga, you've spent some time as a rural doctor. What are some of the more common things that you've been presented with in your time?
I think, like all GPs, heaps of infectious diseases, but in fact, the great burden of general practice these days is chronic disease patients. And just learning to manage patients who are patients with multiple conditions and multiple social factors and who aren't just nice, useful in a packet.
So it's not just coming in with
hypertensive or diabetic.
Okay, so it's
they've
not
got everything.
Exactly, it's not coming in with a touch of bronchitis, David. It's a raft of other things, plus some social factors. Is that what you found as well?
Certainly in a rural setting, you do get to know your patients a little bit more intimately, I think. You find out, often meet them in the street. You'll know a little bit more about their families, about their sons who might play footy with your children, or so you get more of a 3D picture of them as they walk in the door with their perhaps presenting complaint of a cough or a worry about feeling tired. So I think that's one of the strengths of practicing rurally. Certainly trying to keep that all in context when they're presenting is important, and not to get too carried away with talking about what might have gone on at the weekend, though.
Max, you taught general practice and you still go bush occasionally to keep your hand in, as it were. What would you say is the essential difference, or some of the essential differences between being a GP in the bush and a GP in town?
Well, the obvious one is that many of the bush doctors do procedural medicine, so they use a much wider range of skills. The other thing is, it's a bit like David says, I think you learn about people and you do meet them in the shops and everything else. And I learned that particularly with reticent patients, like a lot of Aboriginal patients, and farmers or farmer type people, macho blokes, truck drivers that won't go near a doctor. And you might be in a social situation, or you might be in the local store, and they might say something to you, and that's your opportunity to get at them. And rather than closing yourself off and saying, I'm off duty now, and I don't believe doctors are really off duty, that's the time to grab them and do something. And so I've always done that.
So a lot of your good work is done outside of hours in social settings. Did you two find that in your practice in the bush?
I think it's a bit of a two-edged sword, though, Max. You know, it's great, and I think making the connections was fabulous, and being able to meet people through, in my case, badminton and the aero club and the theatre club and the corporate bowls, which as far as I'm concerned is beer thinly disguised as bowls. That was great, and that certainly made for a much better understanding of the patients. and the people in the town. But then there's just no escape.
Yeah, I mean, I think that, that I would draw the line at being consulted in the middle of badminton. I mean, when I was in Burke in New South Wales, I did draw the line that when I was playing tennis, I said, no, I'm not to be consulted in the middle of a tennis match.
Could this be
people respected that, yes.
Could this be a generational thing? I mean, Max, you're from a generation, or perhaps a generation and a half ahead of these other two young things. Do you think it might be a generational thing?
Oh, it definitely is a generational thing. I can't speak for David, and I can't speak for Olga, but in general, there is a very much a change in the generations. You see this in discussions about what doctors should do when they're called to an emergency on an airline. People of my generation would take the view that you're a doctor, and so you're always going to be a doctor. Some people would take the view, well, hold on, I'm a passenger, I'm not a doctor. And if I'm called, I'm never going to use my doctor title. And there is a view that that I can sympathise with. That look, my job is being a doctor, but I want time off from my job. I have other things to do.
Yes, and I have a life as well.
I think that we don't get told how to boundary set very well, especially when we're at medical school. And I think what the newer graduates, when you speak to the registrars, when they're coming through, they're very much more into this, having a balance between their work and their playtime, and they want to be able to try and work out where those boundaries are. And being able to boundary set is something that we don't.
Yeah.
You can only work out for yourself.
And I guess you can't be giving 100% 24 hours a day, and
No.
the quality of your work might suffer. Let's talk about some of the specific issues. Max, you mentioned macho blokes and blokes who are very reticent or reluctant to present to the doctor. David, the management of chronic pain is something that all our rural doctors come up with from time to time. Strategies for managing this as far as you are concerned?
I think a chronic pain patient might encourage us to feel a bit of some sort of dread occasionally when they walk in the door again and they tell you that they've still got the pain that you've been struggling with for the last 3 or 4 months. But we try and have to, it's part of the pain process is trying to understand where that pain is, whether there is something physically underneath it all, or whether there is some more sort of psychosocial issue that needs to be approached. Certainly having a good policy within your practice about the prescription of strong painkillers, so like opiates, is an important issue, and something that you should perhaps bring up as if you're in a small town, that needs to be discussed with amongst your colleagues, so you don't get doctor shoppers from Perth suburbs who might be getting a bit short on their supplies of certain painkillers, and trying the sort of more accessible rural areas.
Is that a real issue?
Oh, well and truly. And my fondest memories are getting calls from other hospitals along the highway towards Southern Cross saying, you know, patient XY on the way requesting morphine, this is the story, this is what they look like. And they will have tried every hospital between Northam and Kalgoorlie in turn,
Right.
usually ending up at the Kalgoorlie Regional to be dealt with by Dave.
Yes.
The doctor shopper line is a real
It's a real issue.
it's a boon. The whole doctor shopper issue is a real problem. In the last 2 years, there have been 3 coroners' cases, and each of the coroners has said, if only the doctors had contacted each other, then this death wouldn't have happened. Like there was one in Cairns. There's 22,
These people who've overdosed on opiates.
22 doctors, and this patient had consulted 20 of them in the previous 2 months.
Good heavens.
And they claimed that because of the privacy laws, they hadn't spoken to each other. I mean, there used to be a time when we would fax people, and so you would know what was going on. I mean, you get a fair idea of who's a doctor shopper
Sure.
and who's not.
But let me ask you this.
You get a gut feeling.
Many of our doctors, many of our rural doctors, many of our doctors watching tonight are OTDs. They've been trained in other countries. Do you think that they're sufficiently aware and wise to the doctor shopper?
Well, there's 2 very good numbers that they can call. Either the HIC 1800 number, which I haven't got off the top of my head, but I'm sure we can
We
put
can
it
put it on
down.
our website.
And there's also the WA Health poisons information and drugs line, which also has the same information, but at a WA.
But I guess, David, what I'm asking you is, what are some of the indications they should look for to identify a doctor shopper?
The really obvious ones are the patients who say, I can't take non-steroidals. You know, like they've got the list and they've got the medication, you know, they've got the medications down pat, and they usually will present at 5 minutes to 5 on a Friday afternoon when they know that the specialists are going to be there with a carefully multiply folded letter from some eastern states specialist, usually on abstracted stationery. And they'll give you a story that in itself sounds plausible, but, you know, they can't have paracetamol because, and they can't have non-steroidals because, and they can't have steroids because, and they're allergic to this and allergic to that.
They're knowledgeable.
They're very knowledgeable, too knowledgeable.
I believe that I've only ever been caught out once. And this is because the patient came at 6 o'clock, argued about whether they should get Medicare from the receptionist, and I felt that the patient shouldn't have to beg. And he had his arm in a plaster. And he said he had a Colles fracture, and it was very painful. It had only been fixed up at Charles Gardner Hospital the day before, and they'd given him 2 paracetamol or something like that.
Yes.
It was terrible.
So I prescribed for him. I
plausible.
prescribed codeine. I did something else. I got on my bike, and there he was coming out of the pharmacist. No plaster. And I said, "You got me this time, but you'll never get me again." And he said, "It's only a game, doc."
Wow. Well, speaking about people who have drug dependencies, what about strategies to get patients off benzos and other drugs of dependency in a rural setting? Is there anything different that you do that a doctor in a city wouldn't do?
Well, they've got to want to come off.
I think you're better supported in the country.
And and if they really want to come off, then you can get them off, in my experience, slowly, very slowly. A few of them you have to put into hospital. There are a whole number of people that I've noticed who come from the UK, and they're taking unbelievable doses of Valium.
They must have been listening to the Beatles. What was it, Mother's Little Helper? Or?
Well, no, they've had it prescribed. And you say, wow, 60 milligrams of Valium a day, that's phenomenal.
Well, with that weather in the UK, wouldn't you need something like that, David?
No, but they're the people that once you point it out to them, they've been prescribed this stuff in good faith or something bad faith. They're the people that you can get off. And some of the other people, they get such a withdrawal problem that you really have to see them very regularly, or you put them in hospital.
David, how would you cope?
Yeah, I mean, often with people with benzo, they're on more than one type. When you first see them, they might be on Seropax for their panic attacks, or Xanax because they're feeling a bit anxious, and then they take their Mogadong at night, and then diazepam if they're just having a bad day. So you often have 4 or 5 different types of benzo. So the first thing I try to do is get them all onto one drug, so that you can then have much better control of actually how many tablets that you give them. I think in a rural setting, it's often there's only going to be one pharmacist, so a phone call to the pharmacist and an agreement with the patient on how much you're going to prescribe for them and how much they're going to have every day or over a certain amount of time works really well.
You mentioned support, Olga. What sort of support are you talking about?
I think in a country town you've got 2 useful things. You've got all that information about what's going on in their social setting, and so if they come in and they say that they've had a terrible fight with their husband, they have, because the whole town jolly well knows that they have. But I think it's that, the pharmacist, there is only one pharmacist. The nursing staff at the hospital, and there is only one hospital.
So there's a social support infrastructure.
You've got that whole network, and, if they're really trying to get off it, then you've got a whole network of people who are there who can actually help them do it. And it's working as a team with them. And
Without
I don't think you've got that in a suburb.
Well, you might have in the city. You might be able to phone up the drug and alcohol dependency unit and say
you can
goodbye.
do
But
it,
it's
but
much more
it's not kind
impersonal.
of the whole town
You refer them on.
helping
You might
you
not
out.
have those people with those specific skills in a rural setting, but you'll have people who would be able to offer supportive counselling.
And have the genuine best interest of the patient at heart,
That's
because they're part of the community, perhaps.
Yeah.
Let me ask you another one. Chronic fatigue. How do you deal with a patient who comes in and they've already made the diagnosis. I've got chronic fatigue, doc. Where do you start with this one?
Well, I'm feeling
refer them
tired
to
all the
Max.
time, Doctor, is probably more likely.
Well, I see a lot of people who have chronic fatigue. I think the first thing is that you've got to find out what they really do have, if you can. And a lot of them, well, a few of them have strange things. I've had one patient with chronic fatigue that turned out to have Addison's disease. I've had another one who turned out to have hyponatremia. So I think that those ones you've got to go through the list. John Murtaugh's talking later.
Coming up very shortly, actually.
And John Murtaugh's got a book, and in the book there is a list of things, and then one of the diagnoses, one of the chapters is on fatigue, and he lists all these things, you know, the common things, the rare things, the things you shouldn't miss. I think it's worthwhile just to look at that chapter, just that table. It only take a minute to look through that table. And I think that the key is to get them moving, work out whether they're depressed, pissed off, or they've got some other psychosocial problem, but get them exercising very gently. You know, if they can only walk 20 metres, your aim at the end of a week is to get them to walk 30 metres, no more.
Yes, right.
And you've got a long haul, but we don't understand chronic fatigue syndrome. We don't understand
But
it
it's
at
real
all.
and it exists, does it not?
It is real. There is no doubt about that in my mind. It's real. It's real to the patients.
That's right.
So
And
it's real.
So it's real. And doesn't it often affect people who are active? I mean, Alistair Lynch, for instance, a former Brisbane Lions captain, forward, is a celebrated case. I mean, he was an elite athlete.
Well, I mean, there are people that get all kinds of viral infections, and it's a post-viral infection. That's one of the causes. I think that's what he had.
So in a nutshell, a lot of people think they've got chronic fatigue, but it is actually something else.
No, they've got chronic fatigue, but there is another cause.
There's an actual entity called chronic fatigue syndrome, which has a specific set of symptoms.
Right.
And then there are people who are chronically fatigued, who are a very large proportion of many general practice patients.
I mean, and the other thing is that, I mean, I try to keep them away from the people who do very bizarre things to them. You know, tell them that unless they have injections or infusions of vitamin C 4 times a week, they're never going to get better. And they pay vast sums of money for this, or they undergo chelation therapy. I try to help keep them away from those sort of things.
Not a big fan of the alternative medicine, Max, no?
Colonic lavage.
I'm going to say coffee enemas, my God.
I think that if it gets them better, that's fine.
Yeah.
If it makes their pocket very, very thin, and it can, I don't think it's
So
so
that's
fine.
another issue, fair enough. And as for a treatment about people who are pissed off, if you can find one, let me know, because that's something we all suffer from time to time. Now, in a minute, I want to ask our panel about any special, lotions and potions that they may have. But firstly, Max mentioned Dr. John Murtaugh. And remember, if you want to have your say at any stage, give us a call on 1-800-673-277 or 08922 5941. Now, potions and lotions, if you have anything that you swear by, we'd like to hear about those, and I'm going to ask our 3 guests about those as well. But just before we do, John Murtaugh, Professor John Murtaugh, kindly took some time out of a very busy schedule to have a chat with us and share some of his hot tips when he was recently in Perth.
John, welcome to the program.
Thank you.
Could you talk about some common conditions that might present with very atypical features? I was thinking particularly of the recent case where a poor GP registrar missed a case of Addison's disease, which surely is as rare as rocking horse manure.
Yes, well, I've heard about this, and it's something that always worries us. I think any of the diseases, the endocrine diseases, from thyroid through to Addison's disease to Cushing's disease, all these conditions can be atypical and very difficult to pick. There's also what I call the masquerades, which goes with the diagnostic model that I have, and this includes depression and diabetes and drug side effects. All these things can be very tricky, They're what I call the problems that present with undifferentiated illness or vague problems. So you have to have a strategy for them. But the endocrine problems, such as Addison's disease and hyperparathyroidism, for example, are very, very difficult. So you just have to have a high index of suspicion.
They're always the patients that turn up and go, I'm just tired, doctor, all the time.
That's right.
Along with every other patient
That's
that
right.
comes
But
in that
there's a
morning.
whole lot of other things can do that, such as the diseases like systemic lupus erythematosus, the connective tissue disorders and the vasculitides. They are very difficult too. So this is why I have checklists to work my way through. In fact, they sit up on the in the surgery behind the patient's head. So if I'm just a bit concerned, I just use a checklist. I work my way through them. And sometimes the penny drops, hopefully.
So how do you tread that line between over-investigating and missing a very important diagnosis?
It is a very difficult question, but I think that if you have a good diagnostic model, if your guidelines to working out a problem are good, such as tiredness or abdominal pain or headache, your provisional diagnosis should be fairly close to the mark. And if you're fairly good at coming to a reasonable provisional diagnosis, you can be fairly specific with your investigations. But I think it's important that you do have a strategy for investigations, and I have a first line list of investigations which I do on these patients, and it's very simply, I think we all have them, it's a full blood examination, ESR, CRP, always look at the urine and do urea and electrolytes as a first line, and sometimes that gives you a clue to the diagnosis, but I think the point you're getting at is the worry about over-investigation, which I think we do, and I think we have to try and be a bit more specific.
Back to the history and having a system.
And you must examine them. I always remember my mentor said, whatever you do, always examine your patient. And a lot of the mistakes I see are made by people not properly examining the patient.
Do you have any tips for getting the patient to actually spit out the real reason that they've come to see you?
The real reason, I think this is always a difficult one, but I have found something that I think works. I don't say to a patient when they come in, why have you come to see me? What can I do for you? I say, why have you really come to see me today? And if I feel they're hedging around a bit, so now, just wait a minute, why have you really come? I mean, what is your problem? And if I suspect that they're not getting to the crux of the matter, I will then confront them and say, look, I think there's something more deep-seated than you're telling me. I want to know why you really come. Because it might be something that's quite uncomfortable, such as a personal problem, a marital problem, a sexual problem. So I think this is the art of medicine into trying to really zero in on the problem and getting the patient to talk about it.
And sometimes getting the patient to talk about it is quite difficult.
Yes.
Do you have any tips for dealing with patients that you just can't quite establish rapport with?
There are some that you'll never ever make it with them.
Yeah.
But yeah, I think the most important thing is we get back to the fundamental principles of listening. Just spending time listening to what they're saying or what they're not saying. And I think it's always important, if you give them the time and they know that you're interested in their problems, you seem to get a better rapport. But I think it's so important to call them by their name they like to be called by. I always make sure I ask the patient what they like to be addressed by, whether it's their first name or it's Mr. or something like that, or Mrs. And I always make sure, as part of the report, is to use that name. And when they come into the waiting room, I usually like to go out and get them and make a little bit of a fuss of them. And shake their hand, say it's really good to see you, and walk them into the room. But just talk about things they like to talk about. Such as football,
grandchildren,
or racing or something like that.
Yeah.
Yeah, grandchildren's a good one. But just little strategies like that. I think every doctor has their own strategies.
How do you deal with patients who become a bit too familiar?
I haven't found an answer to that, except I don't make a fuss of them. I don't all that business of being really nice to them and being very friendly, that goes out the window with these patients who are a bit like that. I'm just very courteous to them. I don't spend a lot of time with them. I just make it a very matter-of-fact basic consultation and try and cut it fairly short.
And finally, John, do you have any advice for the doctors who are studying for the FRAC GP, apart from buying your textbook?
Apart from buying a textbook? Yes, I do. I think they have to try and get past exam questions. And they have to get if they can, I know it might be a bit difficult for country people, but get in a little group and study together and help each other. I know the people in the city do this, and that's a really good strategy. They have to get hold of past papers and questions and work their way through them. Go back through past issues of Australian Family Physician and look at the questions and the main topics. Get themselves a good medical atlas and look at good photographs of common problems. There's a very good book by Susan Wern on how to sit for the examination. But what I would really advise them to do, and this is what I advise my students to do, as well as my registrars and doctors sitting the exam, is to learn the dirty dozen. I don't know whether people have heard of the dirty dozen, but these are the dirty dozen topics, but I call them the essential dozen topics. And these are the topics that the various health centres around the world have recommended. And I've got a list of them here. I knew you were going to ask me this question, Olga. It's diabetes, particularly type 1 diabetes, chronic kidney failure, which tends to go with the diabetes. So if they know everything about those topics, they know a lot about medicine and they'll do very well in the exams. There's coronary heart disease, there's chronic heart failure, hypertension, which is often related to those, stroke, they must know about stroke, but they're all related, of course, to the coronary business, and so they have to know about hypertension, hypercholesterolemia. There's thyroid disease, particularly hypothyroidism. There's asthma and chronic obstructive pulmonary disease, epilepsy, the sick febrile child, and chronic mental illness such as depression and bipolar disorder. If people know all those topics well, if they get Murtagh's General Practice or any good textbook, and they know these 12 topics really well, they will pass the exam.
Well, on that optimistic note, John, we'll finish. Thank you for joining us today.
That's a pleasure.
Dr. John Murtagh there talking with Olga Ward, and some very good advice, Olga, from somebody who is regarded as the guru of general practice.
Well, there's a man who's been in a lot of general practice consultations with an enormous amount of experience, Jerry.
And this is an interesting question, Max, something he said in that interview, listen to what they're not saying. Now, is that something that you can teach in med school, or is it something that can only come with experience?
I think some people are very good communicators. One of the problems that we have with undergraduates is we take people often who are very, very good communicators, we teach them a different language and they stop being good communicators. And I think that no matter where a person is on the spectrum of being able to communicate with patients, you can always make them better.
Yeah.
I think video is a wonderful medium. People can look at themselves and see what they do. I mean, we all have strange tics, and I've seen one person who kept kicking his leg up and down and denied that that's what he did. So I think that you can make a person a better communicator. I think the worst thing is the doctor that's always in a hurry. I mean, I bought a computer today from a chap who didn't have his mind on selling me a computer. He was on the phone, he was trying to sell something else to someone. And if you get doctors like that, and there are plenty of doctors like that, they really annoy the patients, and you stop communicating and they won't tell you what's going on.
Yeah, we'll come back to that topic in a moment, because I think that's very interesting. But right now we're going to Margaret River, Dr. Alan Wally. Good evening, Alan.
Good evening, how are you all?
Pretty good.
Evening, Alan.
Hi.
You got a question
I have.
or a hot tip?
I was listening with interest about the chronic fatigue syndrome. I have quite a few patients down south with multiple chemical sensitivities, and I'd be interested in the panel's opinion on multiple chemical sensitivities.
Okay, cool. Anything in particular about that, or just a general discussion on it?
General discussion, because I think it's such a hard subject, and a lot of the patients are quite similar to the chronic fatigue syndrome, but more, they certainly get quite sensitive to certain chemicals, or the perceived sensitivity to chemicals.
Okay, cool. All right, you can hang up and listen to the discussion. Thanks for that, Alan.
Fine, thank you. Bye.
Multiple chemical sensitivities. Who would like to have a stab at this one to begin with? So
Well, it's a
looking
tricky one.
squarely at David.
I must admit, I don't have too many patients. I think there was an issue with the Alcoa plant somewhere down south with some of the multiple chemical sensitivity patients. I would be trying to get a specialist involved to actually make a definitive diagnosis. I don't know what your thoughts are.
I think it's very difficult to make a definitive diagnosis, and the debate over Alcoa, there were various occupational specialists with entirely different viewpoints. But the health report on Monday, Alan, contained an entire section on multiple chemical sensitivities. I think the first thing to do would be to try to find out what your patient really has got. I think there are ways of challenging patients with the things that they think they're sensitive to under safe conditions to see whether they react to them. And I think that you can do this in a sort of blinded way, so that you don't know what you're giving them and they don't know what they're getting, and see if they do react to it. It's very similar to the so-called N of 1 studies with different drugs. And I think it's a very useful and scientific way of going about it. And that's the first thing that I would do.
So what would you actually give them? And you'd try.
You'd get somebody like a pharmacologist, and if they said, let's say I'm allergic to milk.
Yes.
You would give them capsules.
Yep.
Large purple capsules, and some would contain milk powders and some would contain things that don't have milk powders. And you wouldn't know. The pharmacologist would know, the patient wouldn't know, you wouldn't know, and you'd see what happens to them.
So one's a placebo and the other's the real thing.
Yes, and they'd have to agree to that, of course. You can't go around deceiving people with placebos. But I think that that's one scientific approach to seeing whether people actually have these
The
things.
other issue, of course, Dan, in places like this, sorry, Olga, I know you were going to contribute to this, is that many people come in already having diagnosed themselves because of some environmental factor, which may or may not actually be contributing to whatever it is that they think or may think that they have. So there's a bit of psychology involved in this as well, isn't there?
Well, if they think they've got something, there's no way that you, especially when you don't know what's going on, are going to convince them that they haven't got it.
Right.
I mean, I recall a paper that looked at people who said they had sensitivities to wheat. I mean, within the alternative medicine spectrum, that's one of the things that people are always told, and they found that only 1 in 40 of them actually had a hypersensitivity to wheat. Similarly, there's the hypersensitivity to nuts.
Yes, which is a common one, I believe.
Yeah.
That's another one, and mothers live with gross anxiety because somebody has told them your child is sensitive to nuts on the basis of a skin prick test. But they've eaten nuts and nothing has ever happened to them.
Olga, you were going to say something about
I
multiple
was,
chemical?
but we've got another caller on the line. It's
He's
Charles
not-
Duplessis from...
I don't think they're
Is he
quite
there?
ready there yet.
Not
no,
ready?
No. So multiple chemical sensitivities a la Olga Ward.
Well, I think the biggest thing for these patients is just to get alongside the patient and acknowledge that whatever it is that they've got that might have a label or might have a different label depending on what fashionable diagnosis happens to be attached to it at the time, that they're really suffering from something, so that and that you're going to try and help them, because I think sometimes you can actually put them offside because it doesn't fit into any of our useful little diagnostic boxes that we have, and
So
the
offering them a light,
characteristic-
a glimmer of hope at the end of the tunnel, a light
Yeah.
at the end of the tunnel, perhaps is an important issue, isn't it?
Okay.
No, the characteristic patient
On the
really
question,
has all those
yeah.
symptoms.
Max, you mentioned
Yes.
that the health report on Monday dealt with this, so if you want to check out the transcript, will be available at abc.net.au/rn/health report. And I know that from just checking it out from time to time. It's a good program with Dr. Norman Swan. Now, potions and lotions. Before we went to the break, we promised we'd ask our panel about potions and lotions. And let me put you the more formal side of the question. Pharmacological favourites, if you have any pharmacological favourites, and do you have any fail-safe recipes for the pharmacist to mix up? Max, you would have probably developed a few over the years.
Well, I haven't developed very many. The only one that I've really developed is for solar keratoses, particularly for bald pates like mine, and it's a mixture of coal tar, about 10% of coal tar, 4% of sulphur, 2% of salicylic acid, 5% of olive oil. It doesn't have to be extra virgin, and the rest of it is an aqueous cream. And in New Zealand you can buy it, and it's called cocoa scalp, but you can't buy it here. And
so you made it up, did you?
I added a bit more coal tar, and then the pharmacist that I use makes it up for me.
My 80-year-old...
100 grams lasts forever.
Yeah, my 84-year-old father-in-law, when he was staying with us over the extended period of the Christmas due to a family wedding, suffered from mozzie bites, as many Europeans do when they first come to Australia because their blood is so rich, apparently. His solution was a mixture of cod liver oil and calamine lotion, which stank the house out.
I can imagine.
And
Mozzies would stay away.
and didn't do anything. Didn't do anything. How about you, David? Any potions or lotions that you've come up with down through the years?
But I certainly don't get any specially made up other than what's normally on script or what I've come up with in the past. I do remember my a trainer when I was at general practice. He had a stuff called Hobbs's ointment, and when he was asked what was in it, he said he couldn't remember what was in it, but it just looked like the stuff that he had when he was growing up, and his mother would rub on his sprains, and it smelt the same way. And so he just had a bit of menthol and some bit of liniment and a bit of aqueous cream, and it looked great and it smelled great, and the patients loved it.
What about you, Olga? Have you come up with
I've got
anything?
a few lotions and potions. I really like tint benzene soft white paraffin, about 1%, sometimes 2% for cracked heels. It's also really nice for mechanics' hands, or brickies' hands for that matter. Just, I don't know what it is, probably the tint benz sticks the cracks together or something, but that also smells wonderful. And clindamycin 1% in Cetaphil lotion for acne.
Yes.
And that's mostly, particularly if you don't like the pharmacist, because clindamycin's very insoluble and they have to dissolve it in distilled water, and it's no end of a bore to dissolve 20 minutes of stirring.
I get the patients to make it up themselves. It's very much cheaper than going and buying Clindatec or going to the pharmacist. And the other thing that I often use that patients can make up is for earwax, and that's sodium bicarbonate, and they can make it up themselves with a quarter of a measuring teaspoon of sodium bicarbonate and 10 mils of boiled up water, and they shake it up with a dropper, and it costs approximately less than 1 cent.
Sure.
Whereas if they buy it at the pharmacist, it's about $12.
But once upon a time, and I go back to the generational thing again, once upon a time doctors did a bit of experimenting, became sort of amateur apothecaries, if you like, in order to arrive at a solution. Do you feel that doctors are not perhaps just experimenting enough with potions and lotions these days, or do young doctors think that this is not my world, I'm staying out of it?
Well, they don't have to. I mean, it's all there.
There's enough out there. Yeah.
There are things like potions that I used to use for plantar warts.
Or plantar warts, yeah.
And this was developed in Northern Ireland, sort of a bit further north from where you come from.
I'm going to stop you there. Do you still have that recipe?
Yes.
Because we might actually put it on the website, because we're running out of time on this particular one. At the annual conference, there was a lot of discussion about the role of the GP within rural communities. In particular, we had a panel to discuss the value of formal and informal GP involvement in community decision-making. Well, we caught up with some of the panelists and other participants at the conference and asked them what they thought the key issues were in relation to the role of GPs as community leaders.
The GP in the town tends to have a far broader understanding of what's happening below the surface in the community because they see people. They know what sort of mental health problems are around. They know what sort of perhaps trails of particular illness there might be. So therefore they have an enormous amount to contribute.
Councils don't come to you and ask your opinion about their primary health programs. And yet you must have, if you've been there longer than 2 or 3 years, you've probably got a high understanding of what's not working, what needs to be done.
You see how the community works at a very deep level in homes and at work, all around the community. You see the causes of the illness that comes to your practice, and yet mostly your opinion is not asked in decisions made by local government and any regional council you have.
I think that doctors are a bit shy about being involved and they don't really realise that they can make a big contribution. And I think that's partly that they're really busy and they get so busy doing their day-to-day work that they don't think about the big picture, and it's not until somebody actually comes into them and says, what do you think about this, that you'll actually find they've got some really good ideas. So you've got to actually actively go and ask them.
I think a lot of us would like to have our ideas about how things should be done, but we don't always have the commitment outside of work to follow through with them. So we're probably happy to go to meetings and say, I think this should happen, but to actually then go and be the person to try and drive that, we don't always have that time and energy to do so because we prioritise our time off to other things.
This is where we need some leadership, and I believe that probably somebody's got to put up their hand and take that role. And in rural WA, I suppose one of the reasons why I'm going to WA Country Health Services is I believe that they should take a much more active role in actually trying to lead some of the groups together.
I know as a medical practitioner, a lot of people do take notice of what you say, and it is an opportunity to get involved in local government decisions and have an influence on some of the facilities that are provided in our community. And I'd certainly encourage doctors to maybe get involved either at a local government level or certainly at a community club level, just because it gets you out of your practice, it gets you out of your surgery and provides an alternative.
And it's not just being part of it. Sometimes we're very good administrators, and so being part of administration or organisation of these bodies can be very helpful, not only for the organisation but for us as well. So I think, yes, GPs have a lot to contribute, but they have got to have the time to do it. And I think if they're getting burned out or stressed or working very long hours and don't have the time to do it, I think that's dangerous.
If you want rural doctors to become involved actively in planning rural health services in their community, there needs to be a mechanism for how you can reimburse them because they're very busy during their day seeing patients. So if you do the meetings at night, they may be able to go then. But if it's during the day, and often the health department will run its meeting on Monday morning at 9 o'clock, and that's obviously a time which is probably the busiest in any GP surgery when you've got all the backlog from the weekend. So having the meetings at times that suit doctors is really important. So you've got to look at the timing and talk to them about when those meetings might be.
And I'd encourage some of the doctors to look at local government. You'll probably find it be fairly easy to get self-elected onto a local shire or town or city council and try and exert a bit more influence outside of what you do on a day-to-day basis in your medical practice.
You'll recognise Dr. Mal Hodson there. That was from our recent annual conference. Now, it's a topic, as I said, we devoted an entire panel session to at the conference, including having the input of Dr. Barry Jones. Max, what's your view on the role of GPs in community decision-making?
Well, a GP really can be an agent of social change if they really do want to. I read a book about it. It depends how much energy the doctor's got. I mean, there are plenty of GPs that have got to be in their bonnet about something, and they've done great things. I've seen GPs sort of running around and fighting against all the odds to get a swimming pool for their town, and succeeding in the end. It's taken a lot of energy.
Mal Hodson is an example of GPs who have become very actively involved. He was on the council in Kalgoorlie. Do you advocate that kind of thing? Do you advocate doctors actually, standing for elected office while still being the local GP?
Why not?
Can they cope with both responsibilities, do you think?
He did. And he represented the Kalgoorlie at tennis at the same time.
We could ask Dr. Graham Jacobs, who's MLA
for Rowe at the moment.
Yes, MLA for
Or
Rowe.
Ernie Mania, who was the
Mayor of
Bunbury forever.
Yes.
One of the points that we discussed at the conference was the overseas trained doctors who often come with a different perspective on how things can be achieved in communities. Do you think that we readily look to them, or we readily accept that they've got something to offer in the communities?
I think they have a lot to offer, but I think that it's going to take most OTDs. You know, if they're English speaking or they're South African, they get into it pretty quick. If they're not, I think they have great difficulty. If they come from the rest of Africa, it takes them a while to find their feet, and I don't think they're going to be too much involved in community things while they're finding their feet and trying to survive each day as a doctor.
All right. Well, the other issue that we discussed at the conference was the question of sustainability. And at the conference, our producer asked some of you to give your thoughts on sustaining a rural practice. Here's a sample of their thoughts.
For me, one of the biggest things that keeps me in Esperance and makes a difference to me being in practice is having a good team, good relationships with a stable group of nurses, allied health professionals, my colleagues. That's what makes good living and good working relationships.
It's definitely having hobbies outside of work and having a life outside of work. I think it's very easy in rural and remote practice to get engulfed in the work situation and patients and the care and the hospital politics or the whatever politics. But I think it's very, very important to have hobbies, whether it be swimming, sailing, camping, getting out and about, whatever. And I think that's what keeps people in the area, because they love the things that they can do outside of work. And to make the time for it, it's very important as well. Using your time off effectively, not just sleeping, which I think a lot of, well, I certainly did in the past. Days off you'd sleep because you were just exhausted, but you've got to make the effort and mix with non-medical people and get involved with clubs and sports and things like that.
I do something silly. I act and I direct plays for a local repertory club in Geraldton. And although I don't claim to be a great actor, I do enjoy directing because it allows me a sense of power to order people around on stage. So that's one of the things I do to let off steam.
Survival to the northwest is to make sure you get plenty of breaks, that you don't rely on the best coffee in town, and that you have a great friend network outside of your working life that you can catch up with on a regular basis. Plenty of trips down to Perth and enjoy the work in the town that you live in, because that's really why we're still there.
Of course, we can always fly into civilization. There's a 2-hour flight. Not much of a problem that way. So we come into civilization once in 3 months just to have a taste of what civilization is, and then we go back. That's it.
Keen on playing tennis, so I belong to a local tennis club, and I think it's another way of getting involved. You can support your local team or organisation, become a club doctor for a footy team or whatever, and it just adds to the mix. It just broadens your exposure, and I think it would make your stay in your country town much more rewarding.
At the moment there is no incentive for doctors to go bush, so that's why we rely on OTDs, because the Australian doctors have no incentive to go to remote areas. They don't perceive they have the support, they don't perceive they have the need. And so the only way you're going to be able to get doctors there is to force them somehow. Otherwise, either be overseas trained and have to go there, or put them on bonded rural scholarships. And that's not really the way to do it. You need encouragement, more carrot rather than stick.
I guess my tip's that they recruit people who are country kids, been brought up in the country, more likely to go back there to live and work in their area where they grew up, or other country areas.
You can't fix everything, and you don't even try to fix everything, and I think in a way you're more effective for a patient or for the individual when you acknowledge that and you don't feel beaten by their problems. And I think that's important to remember, that you go to work and you come home and you relax, and as you come back to work you're more effective for the same people with the same problems.
You've basically got 3 baskets of eggs. And you've got 1 basket of eggs for yourself, 1 basket for the family, and 1 for other people. And you've really got to make sure those eggs are beautifully distributed, or else your life will be out of balance. You'll either be divorced or burnt out as a doctor. So you really do need to look at that in your life balance. It is not all about medicine, it's about enjoying life as well.
and a solid recommendation there not to put all the eggs in one basket, otherwise you get divorced, you get burnt out or what have you. That's what it's about really, isn't it? Trying to effect some sort of balance, David, when you're working in rural communities?
When you're in a rural community, it's very easy to be sucked in, to be on call all the time, to try and make yourself available all the time to be everything to everybody. So you do need to be able to boundary set, be able to make sure you factor enough time out of town, or when you're in town to really be able to put up the shutters and let people know that you're really not available.
But still be available to, as Max said earlier in the programme, to be able to at least interact with people on an issue outside of them and then take it to the surgery, during surgery.
Sure, socially, if you're at the footy game and someone who you know should be, is it just newly diagnosed diabetic, say, and they're just tucking into the half-time cake and chocolate and everything else, you might say, well, yeah, do you remember what we spoke about, and we should really perhaps just refocus that next time you come down. That's a kind of useful thing, without them telling you about their piles and you know, remind you about the last
Which can put
PI
you off
had.
the Frankfurters.
That's
really,
right.
fair enough.
Yeah.
Now let's talk about you know, succession planning. I guess many rural doctors go to a rural practice, especially if they're not from that area, stay for a while and come back, and we've seen that happen down through the years. But how do you go about succession planning in a situation like that? Max, have you got any ideas?
I've got a few ideas. I think there are some good models around. I think one of the best models was discussed at the 2020 Talkfest, and it's the Rural Doctors Network of New South Wales, and it's called Gracious Entry, Easy Exit. No, Easy Exit, Gracious...
Easy entry.
Easy Entry, Gracious Exit. Easy Entry, Gracious Exit, sorry. In which the shires, a combination of money from local government, from the Rural Doctors Network, from state and federal governments, funds communities and practices to which people don't want to go, or places that people have found very difficult, like Western New South Wales, where this was piloted. And the doctors can come in there and they can work there for a year or for 2 years. They don't have to worry about the business aspects of it. It's all done by the Shire.
So in other words, the Shire owns the practice.
The Shire owns the practice, and the Shire is responsible for the succession planning of the practice.
Now that's fine and dandy, and that works, but we had Bill Mitchell, who's the president of the WA Local Government Association, at the conference, who said, listen, it's not our responsibility, it's a state or federal responsibility to provide health. Why are we being lumbered with it and getting sweet bugger all in terms of funding for it?
Well, I mean, shires normally look after roads, rates and rubbish. I noticed going through the wheat belt that they also look after recreation, and they do it very, very well. And they've been left with finding doctors because no one else is finding doctors. Right. But in Western New South Wales, with the help of the Rural Doctors Network, New South Wales Rural Doctors Network, with a chap called Ian Cameron, the shires have said, okay, we recognise that if we want doctors, we have got to find the money, and the money's there, and we've got to provide the support. Because doctors who come into a place for a year or 2 years, they don't want to be doing financial aspects and financial planning. We're not good at that. We're absolutely lousy at it, most of us. We don't want to do it. We're not interested in that. Most of us are trained to treat sick people. And we're interested in sick people, and we're interested in stopping them getting sick. And that's what we want to do. And so if you set up, and then we don't want to get guilty, you know, when our spouse is saying, look, you know, the children have reached high school age, I've had enough of this. We don't want to feel guilty about saying we've got to go.
Okay, but shouldn't somebody provide the funding to the Shire to provide that service?
Well, that's what's happening in Western New South Wales.
David?
I think encouraging young doctors to go out and have a go at rural health is key to getting succession happening. If it's too difficult, if you've got to think about setting up a surgery and employing people and understanding Medicare down to the last detail, as a young graduate, you're not going to go anywhere near a rural practice. But as Max was saying, if you can have a sort of walk into a ready-made practice, commit to practicing for a year, say, to get a feel for what rural practice is like, you'll find, as we found when we did that, we loved it. And so we didn't just stay for 1 year, we ended up staying for considerably longer, which then allows more people to come and try the same thing.
Yeah, I think the registrars do get a pretty reasonable sort of rural experience, or at least most of them do. I think the other group that's been significantly under-targeted are the people whose kids are through high school into university and they're looking for something different. They've got experience to offer, you know, and maybe they don't want to be tied to their practice in the city, and this is an ideal opportunity to kind of go out. And I think that's a very under-marketed market, so to speak. People who just want to go, and again, if it's easy entry, gracious exit, they can go and have a shot at that rural practice for a couple of years and rediscover their procedures.
Are we accepting from what you're saying then, that the notion of getting a doctor to go to a community and stay there and become part of the community, we've given up on that?
No, I think that there are many models. There are very many models. I mean, doctors are quite attracted to salaried practice, some of them. In Western Australia and many of the towns, it's salaried practice. The doctors like that. Those sorts of doctors.
They don't have the other headaches.
They don't have all the headaches. If they're funded by the state government, they're very well supported. They get locum relief, they get holiday relief, they quite like it. So you've got to set up different models that will attract different sorts of people. But the days of people coming into a town that's barely medically viable and buying the practice, I think, are over.
So the idea in those kind of situations where towns themselves, some of them are barely viable, is for the Shire to own the practice, but get some financial support from state or federal in order to run that practice.
Absolutely.
Ideal.
And then, as you said, I think doctors who go into a rural community, you go into a rural community to join a rural community. So, you know, and if you've got people who are there to have a go at rural practice, generally they're people with a mindset of getting involved in a rural community. And so the other things follow, the joining the tennis club or the baddie team or the footy team.
Sure.
God help us.
I mean, the Shires don't like it, but if you look at what the Shires are providing for many doctors, their practices are much better than just about every practice in the Perth metropolitan area.
Fantastic Shire deals out.
And on that, I'll say thank you for joining us this evening. That's our program. Don't forget, if there's any part of this program that you would like to review at a later time, a delayed transmission of the Rural Doctors program will be available via internet web streaming from next week. Now, this service is accessible through the Rural Health West website at www.ruralhealthwest.com.au, and please note that the internet transmissions are password protected, so if you haven't already, you'll need to register by contacting Rural Health West. Do be warned, though, that this service is best for those with high-speed broadband. Wherever that exists, let me know. We'll be back again on the 3rd of June, when we'll be taking a look at some successful programs in Indigenous health and trying to identify some common characteristics of those programs. We look forward to your company then. From our panel, Dr. David Jamieson, Dr. Max Kamian, Professor Max Kamian, and Dr. Olga Ward, thank you very much for joining us. And Max's potion, we will try and get that up on the website as well. Thanks to everyone else who was involved in the program. And for me, Jerry Gannon, good night, and thanks for being with us.